Hi there, Regitze here. What is minimally invasive treatment to me? I'm gonna show you a simple treatment and try to teach you or tell you about my beliefs. Well, it's actually all about creating win-win situations for me and my patients. I work like most people. I want to make a living out of my work. I want to make money. And my patient, they want to have healthy teeth, nice teeth, and have as little problems as possible with their teeth. So I work for creating win-win situations in that cooperation. And then I want a stress-free life. I hate these days at the office where we have a lot of catastrophic treatments and outcomes, failures. I don't see them that much. I have seen it. It's you know, it can ruin your day when you see this poor patient coming in with a broken root because of a corn post and crown, and then we have to extract the tooth and we're gonna do an implant or a prosthesis, and the patient has no money, and or it's difficult for them to raise the money. You know, this is not a happy patient, and it's a stressed dentist, and it takes a lot of work and a lot of communication. So I really want a stress-free life, and I can get that by doing minimal invasive treatments. Then I want to save tooth structure, because I know when I save tooth structure, then I'm going to create win-win situations and a less stressful life. And I do that by distributing forces and creating good balances in the bite. And I do it by having fun with bonding, occlusion, composites, and ceramics. And this is great ways to work, because you can do all kinds of treatments here. You can do highly aesthetic, very expensive, very nice treatments, and then you can do low cost treatments with direct composites, not very aesthetic, but you can change a lot of things for these patients. You can buy them time, you can buy them great teeth, and you can still make money on this. And this is great fun. And I'm gonna show you just a short example of a treatment. It's a direct composite treatment. It's not highly aesthetic, but it's a good example of what is possible. And I'm not a photographer, and I could learn a lot about photographing, but this is not a course on photographers or on photos, so you will have to bear with me with my quality in pictures. But let's take a look at the picture. This is a lady. She's 52 years old, and it doesn't look that bad. She has nice teeth. They're not, you can see the amalgam fillings, but if you look closer, you can see some wear, and well, okay, it's on the canines. It's not that bad. When she opens, you can see some of my blue stains from the occlusal paper, but never mind. It's not gonna mean anything. She is wearing her teeth, and it's worse in the left side than on the right side. She's got some crowding in the lower anterior, and we can talk a lot about orthodontics and things like that, and secondary eruption and everything, but we'll keep it simple. When you see this patient in the upper jaw, you suddenly notice that a lot of things is going on, and it's not just wear on the canines, and actually it's a lot of different things going on. In the front area, anterior region, she has this palatal wear into her incisors, and especially on her left side. That's the right side on your screen, but especially the canines and the central and the left lateral is worn. Not that much on the incisal edges of the incisors, but on the palatal surfaces we have big areas of exposed dentin. So what's going on there? And what's going on in the posterior regions on her right side, well, there's signs of wear, there's signs of erosion, but it's not that bad. I mean, she doesn't have cracks or a lot of decay here. That's pretty calm on her right side. On her left side, on the other hand, you see all these things going on. Cracks, decay, amalgams that are failing. What's the difference on these sides of her occlusion? That's a great question, because she is destroying her left side, but she doesn't destroy her right side. And we can ask ourselves, is it just because she's making more lateral extrusions to her left side? But when you see how she goes into excursions on the right side, she has great disclusion. On the left side, she discludes her posterior teeth, but not her incisor teeth. So it's not just this that is ruining her posterior teeth. So what's the problem? We can just take a look at the lower jaw. It's not that bad. There's a little wear, and especially on the molars, the second molars especially, but a little wear on the anteriors. It's not that much, but it's okay for me, this wear. But there are signs that she's wearing her teeth. So what's going on here? It's about occlusion, this. And one of the things you have to learn about in occlusion is point of first contact in centric relation, which I call CR. And this can be very important when we check patients, when we treat patients. So it's a position that it's nice to know about. So if you don't know about the point of first contact in centric relation, stick around and you'll meet it in my training. But what is the first point of contact in centric relation? Centric relation is when the condyles is seated in the fossas as well as possible, and I won't discuss it further here, but when the condyles is seated and the patient close, they don't necessarily hit all their teeth. They might only hit one tooth. And from that point, also called the point of first contact, they slide into the centric occlusion, what you call maximum intercuspation or something like that, intercuspational occlusion, and that's where most teeth hit each other. But if they have a first point of contact that is worn a lot, or where the patient is grinding during nighttime or during daytime, it might look like this. And her point of first contact is on this second bicuspid on the left side. This is the problem tooth here on the left side. She's got a huge crack, and when her condyle seats, she's on this tooth, and then she moves on this tooth and on some of the other teeth in her left side and goes forward into her anterior teeth. So this initial contact is guiding her. It's an interference in her bite, in her occlusion. And this is gonna ruin her tooth there, and eventually some of the other teeth too, maybe even the first bicuspid eventually, if we don't do anything here. So this is about protecting her teeth against further damage. And we do that by raising the occlusion, opening the occlusion, and in this patient it's done with direct composites. It's an add-on treatment, and we get back to this philosophy about not removing tooth structure, so that we can save as much as possible, because it will make our life much more easy in the future. So before we started, she was like this, and then we just put a little on the palatal surface and a little on the canines, the incisal edges, and there's a little on the front. I haven't polished it that well, so you can see my non-polished work, but that's not the essence in this in this small video. This is just how we save teeth from wear. This is with the composite, and it has opened her bite just a tiny bit, like a millimeter, and then we have put it composite on the posterior teeth. We've taken out the amalgam fillings and made a new occlusion for this patient. So now she is biting on a new vertical dimension on all teeth in both sides, and she needs some polishing, but that doesn't matter. She's away from ruining her teeth, and now we have taken away all the points of first contact for now. It might change in the future, and we'll have to control her. So her left side, which was her problem side with the first point of contact, we removed the amalgam fillings, we covered the cusps in the new occlusion, and now it's much more safe for her to bite and to sleep, to use her teeth. And she might never have problems with these teeth. We might change the composite or make a porcelain onlay, ceramic onlay in the future. But for now, this is doing great for her. So remember, when you do these treatments, it's not difficult to save teeth. You just have to be there on the right time with the right treatment. And this is what I can teach you. And I've done all the other stuff. I've done full crown treatments, 28 units. I'm never going back to that. It's horrible when something goes wrong. And this is not difficult. And you know, you can't do that much wrong. It's so easy to repair. It's so easy to change it. It's easy to do it high aesthetically. It's easy to do it cheap and fast. You know, you can treat all kinds of patients with all kinds of financial possibilities, all ages, and you're going to do fine. So I wish you great bonding out there, because this is what it's. One thing is occlusion, but your bonding, you have to be in control of your bonding. So check out your bonding, do courses on bonding, be great at your bonding, because this is going to be the future. Bonding in dentistry, composites and ceramics, and do it with occlusion in your mind and with minimal invasive offset in your mindset. Well, this is it for now, this little teaser. And if you want to learn more, I'm Regitze, and I'm the Biomimetic general dentist from Denmark. If you want to know more, then sign up on my list. I'll put the link below this video, or you can visit my site, Biomimetic-smiles.com, Biomimetic-smiles, I think it's called, and I'll see you there. I will be so delightful to meet you, and I can tell you I have a lot to teach you or inspire you with. So see you there. Thank you.